Thank you so much, Dr. Shawqi. It's my pleasure to be with you today. All the thanks for my colleague in Bayer for this excellent, valuable education activity. So to start with, I would like to ask the team, do we know any one of you, this paint, it's related to what?
Picasso, for sure.
So it's a Picasso, it's called Women of Algeria. So it's worth $100 million. So, in 2015, there was no actually big changing practice trial. However, I'm going to discuss three trials. The first trial was TRIBE trial, where the first line metastatic colorectal cancer, 508 patients, randomly distributed to FOLFIRI-bevacizumab head-to-head with FOLFOXIRI-bevacizumab. And there was a maintenance dose with a 5 FU. Keep in your mind, the question for this trial is adding oxaliplatinum. It's an increase overall survival or progression-free survival. The primary endpoint was progression-free survival. Secondary endpoint was response rate. Secondary R0 resection rate, overall survival, and safety profile, and finally biomarker evaluations. So eligibility criteria was clear, histologically proven adenocarcinoma, unresectable, first-line treatment with excellent performance status and adequate bone marrow, liver, and renal functions. In this study, we can see there is a nice separation between the two arms with a almost 4 to 5 month benefit with adding FOLFOXIRI plus bevacizumab if you compare it to FOLFIRI chemotherapy and bevacizumab with excellent significant p-value. What's interesting actually, as you can see, all the patients based on stratification factor was in favor of FOLFOXIRI chemotherapy. Okay, this is the most important slide because simply they did what's called molecular analysis. They divided the patient to RAS and BRAF mutant wild type, and BRAF mutant type and RAS mutant type. And as you can see, for those patients who is RAS and BRAF wild type, they reached to 37.1 months. And for the RAS mutation, 25.6, and for the BRAF mutation, it's reached to 13.4. So, what about the progression-free survival? This one? Okay. So the progression-free survival, there was at least 2 to 3 months with a nice separation in favor of FOLFOXIRI bevacizumab chemotherapy. However, if you can see the updated survival in GI ASCO 2015, 3 years and 4 years and 5 years overall survival, as you can see, the very significant difference between the two, almost 10% between the two arms. So, in the term of the summary, the progression-free survival was very significant with improvement in FOLFOXIRI befa chemotherapy. Overall survival again was very significant. Response rate, however, the resection rate was actually non-significant. So, the take-home message for FOLFOXIRI bevacizumab can be considered as a first-line treatment of metastatic colorectal cancer in only one situation if you have special order from high administrations. Simply why? Because simply it's a very high toxic. Simply there is no clear advantage. And number 3, if you start with the patient with FOLFOXIRI chemotherapy, unfortunately you don't have a second line therapy. So the only condition I may consider FOLFOXIRI bevacizumab for this patient who is potentially resectable. This is the only situation which I could consider adding FOLFOXIRI bevacizumab chemotherapy. So for Dr. Khalid and Dr. Shawqi, let me ask you regarding the BRAF mutant type, what's the usual from your experience, how you are treating a patient with BRAF mutant? I know that's unfortunate, we don't have data about the BRAF in the kingdoms. However, suppose we have a BRAF mutant type, are you going to consider FOLFOXIRI? Because we know simply before that FOLFOXIRI is the best treatment for the BRAF mutant type. Shawqi and Dr. Khalid?
As a matter of fact, there is a publication by Dr. Khawla Al-Karaya, 700 cases from King Faisal Hospital. BRAF incidence is 2.5%.
Okay.
So it's very small, and that's why we really don't make the effort to look for those patients with a BRAF mutation. But it was
so Shawqi, if you have a patient with a BRAF, for example, you have a BRAF patient, what's usually? Are you going to start the same FOLFIRI bevacizumab then if you progress FOLFIRI beva, or what's your experience?
Now, theoretically, I tended to disagree with this message that you gave. Personally, I like the FOLFOXIRI bevacizumab because
in which conditions?
Because, I mean, you have a 25%, 1/4 of the patient are alive at 5 years. It's
Which is
worth
excellent,
it.
yes.
Remember, those patients did not get folfoxiri till progression.
Yeah.
They got folfoxiri for 12 cycles and they were maintained. So it's only the initial period that they had intensive chemotherapy. Yet, with this intensive chemotherapy, regardless of what second line you want to give, although there's a lot of published data, and we actually are looking at the second line in patients who get triplet, because we have published Zeloxiri,
Yes.
and we're now looking at our second line and what's the PFS for the second line, etc. So there are those patients who are very symptomatic, big volume disease. I think they would probably benefit from folfoxiri if they are in good performance status.
Excellent. Dr. Khalid?
So actually, I would agree with Prof. Shawqi. So I mean, a couple of things. So the BRAF study has been published 2014, actually, with the data from Security Forces and King Faisal. We did actually our own series with the Lynch and the BRAF, and actually we agree with that. A very low mutation of BRAF mutation. We haven't published that data yet, the Lynch and the BRAF incidence in colorectal cancer.
So what's expected? I mean,
So the BRAF mutation in Saudi population is low. It's about like 1% in our cohort.
Okay.
So now that's number one. Number two, actually, there's a small phase 2 trials about inhibitors for BRAF, and actually it failed.
yes.
So we know actually BRAF is prognostic, but doesn't predict anything.
Yeah, definitely. Definitely.
So we know it's actually patient going to do bad. Now for this trial, actually, it is a bit of a problem. Now the trial actually looks very convincing. Let's be clear. The trial showed actually an overall survival benefit, even though it was actually meant to be a progression-free survival. Now we can worry about the second line, but to be honest, that is very good. Now the problem is highly toxic, especially in our population. I was going to say, if you try this, highly toxic.
I tried 2-3 times. It's a very high toxic.
And that is my only problem with it. Other than this, I can't argue against
I
that.
only consider it only in patients with potentially resectable, where I would like
Actually,
to have...
you know, actually, the point about the resectability, she was the weakest thing on this
yes,
trial.
yes, definitely, definitely.
But I mean, the survival data actually difficult to argue against, except from a clinical practice, very tough.
And we reached 37, and as Shawqi mentioned, I mean,
profound
15%
area
at the 5 years. It is excellent. Okay, so
even in pancreatic, and they did very well, and we didn't find this hypotoxicity.
You're gonna be the point. To be honest, I would say it's a very highly toxic. Now, let's remember actually, trial cases, they will select typically the greatest performance status. If you're gonna start to apply this across the population, you're gonna expect the side effect are gonna go up. That's actually what typically will happen in any trials.
definitely.
I want to ask Dr. Shawqi, what's your experience with folfoxiri BEV with persistent neutropenia? We find several patients, if they receive after 3 cycles with the full dose in a very fit patients, some of them have persistent neutropenia that we couldn't continue the treatment. Do you face
Despite
this?
GCSF?
Despite of GCSF, yes.
I haven't.
So I
faced
think
it.
it depends on the selection of the patient.
Absolutely.
It
You
should
have to have
be
somebody
very,
with a performance
very
0 to 1.
good selection. But
Absolutely.
even after that,
0 to 1.
then after that also the hematologic response to the patients, because we have selected these patients, but we have bad experience with this.
And this trial, 40% they were neutropenic. They have chance of neutropenia.
Wouldn't be
So
surprised.
40 is a good number. So the second picture, anyone can know what's the pictures?
No, this is Dream Norwich.
No.
Starry
39 of Fanjour. Excellent. So this is a worth $450 million. So the second line is raise. Yes. I will show you the next 2 painting, and you'll find, I mean, it's very surprising. So the RISE trial, actually, it was a second line trial where they're looking for metastatic colorectal cancer post-Folfox. You remember the Filor, the Aflibercept? It's exactly the same, with excellent number, 172 head-to-head Folferi ramucirumab with Folferi plus placebo, and the primary endpoint was actually overall survival, secondary endpoint was response rates, progression-free survival, and safety profile. So the eligibility criteria, it is the most important thing. Those patients as a second line who has progressed on Folfox chemotherapy. Interestingly, when you see there is a nice separation between the 2 arms with 1.6 month overall survival benefit with significant p-value. Again, if you see the progression-free survival, there was a 1.2 improvement in progression-free survival in ramucirumab line. However, if you look for all the second-line treatments, so you know the ECOG 3200 with the 3-arm FOLFOX plus bevacizumab and bevacizumab alone, and it's, as you can see, there was almost identical. There is no big difference. So adding ramucirumab, it's a very expensive medication with all side effects of vascular endothelial growth factors, DVT, high blood pressures, bleeding, all the complication. Is there any benefit from this medication to be in second line? So I would like to hear from, again, Dr. Shawqi and Dr. Khalid. Do you think there is any chance for ramucirumab in our practice at the meantimes?
I
Dr.
don't have
Khalid?
an access to ramucirumab.
Sorry?
I don't have an access to this drug. But even if I have an access to, I doubt I'm going to be using it.
Excellent. Okay. So, Dr. Shawqi?
So let me tell you, initially we had bevacizumab that improved survival in second line.
Which is a TML, yes.
Then we got the Velour trial with the aflibercept, and we never used it because it's a Me Too drug.
Yes.
It's just doing the same thing.
Yeah.
And now you have ramucirumab. I really don't know why they did this trial.
Excellent.
Just maybe it's a proof of concept that second line anti-angiogenic therapy.
It's better than IGFR, yes, definitely. So, any comments from the audience?
But to tell the truth, I don't see any role for it. I don't think we will be using it because we have bevacizumab. We're using it the first line. We can go with the second line.
So, we are in the same consensus. Any comment from the audience? Dr. Fuad? Okay. Prof. Qandil? Agree. Dr. Ashraf?
Even in third line, I think we will not be able to use it because most of our patients will be already used irinotecan at the previous stage. So I think that the chance of using it will be very minimal.
Dr. Muhammad? Okay, fair enough. So the third pictures, I think everybody know this lady. So, anyone?
Doesn't know.
No, I will tell you how much, but do you know who's this? Huh? And who's the one who paid it?
Da Vinci.
Da Vinci. And it's worth, ya جماعة, $1 billion. It's 1 billion يا شوقي. أنا وأنت جالسين يا شوقي في الأونكولوجي with those painting 1 billion. 1 billion. So it's worth it, I don't know.
Worth going to France and stealing
I
it,
think
huh?
so. I will show you the last pictures. This post-op. Yeah. Okay, the third trial, actually, it's Concorde trial. We know the first trial for regorafenib in placebo in the third arm, line, and fourth, it showed clear overall survival. So the same study, Concorde, is a phase 3 trial where pre-heavily treated metastatic colorectal cancer to regorafenib, they randomly assigned to regorafenib and placebo in Asian patients. So I do believe we belong to Asia. So the inclusion criteria, male and female more than 18, histologically proven adenocarcinoma of the colon, patient metastatic colorectal cancer who progressed in second and third line of therapy. They allowed to receive bevacizumab, anti-EGFR, cetuximab, and panitumumab. So the Concorde, the primary endpoint was actually overall survival, and you can see at least there is a 1.6 improvement in overall survival with regorafenib as a third and fourth line, and with a very significant p-value. As you can see in the subgroup analysis, most of the patients actually they benefit. However, for those patients who has no prior chemotherapy, no prior targeted therapy, they actually respond the most, and as you can see in the second slide. The progression-free survival was in favor actually of, was significantly with the regorafenib head-to-head with a placebo with a very significant p-value. What's interesting here, actually, you can see there is a nice separation for those patients who did not receive prior therapy anti-vascular endothelial growth factor or any targeted therapy. You can see they reach to almost 9.7 months with a nice separation between the two arms. So in regard of the side effect, as you can expected, most of the side effect was actually abnormality in LFT, high blood pressures, and hand-foot syndrome or palmar plantar erythrodysesthesia. So in the correct trial, as you know, the first trial, which actually they compared regorafenib head-to-head with placebo, you can see there was excellent overall survival benefit. So this study, Concord and correct study, it's confirming the benefit of regorafenib in third and fourth line of the therapy. So the take-home message, this is because of we are invited today by Bayer. Regorafenib showed the benefit in third and fourth line with great median overall survival, and safety profile is manageable with acceptable toxicity. So let me hear from Dr. Shawqi and Dr. Khalid. What do you think about regorafenib as a third and fourth line?
Not because it's Bayer's. I have no problem with using it at all. I think if you know how to
Select the
teach
patients.
your patients and preemptively treat the side effects or prevent the side effects from occurring, I had no problem.
Khalid?
And alhamdulillah, now I have the first patient who is now 5 months on regorafenib, because normally all of them progress after on the first evaluation.
Yes, excellent. Dr. Khalid?
So I would agree with the same. Now, my only things, I'll say I have no patient which is maintained on the standard dose 160. Nobody can tolerate that, to be honest. So I have patient at 120, I had a patient at the 80 milligram, but the 160, I'll tell you, all the patient falls apart.
Okay.
And we had a few pictures of them, and she showed the extensive diarrhea and extensive skin rash. Skin rash very significant. And regardless, whatever you want to treat it like an anti-EGFR, doesn't work. It just needs some time to recover when you stop the drug.
So I use it for 4 patients. One of them reached 5 months, Dr. Shawqi. And the 3, as you said, within 2 cycles, they progress. So the audience, any comment, Prof?
Yes, I think the majority tolerate the 120. But very occasional patients that will tolerate the 160.
And actually, I think the trial actually showed many patients, actually, I forgot like the exact percentage, 40% like required
Yes,
dose reduction.
almost, yes. Yes,
So
42.
that tells you actually it's quite
42, they have those reductions. Dr. Omar Shahir, any comment? Okay, so the last slide, this is the most important painting pictures.
That's your kid.
As you can see, there is no, please, please, just a minute. There is integration between the color, and it gives you some idea behind this. And it's worth actually 5 riyals. If anybody interested, I can give you the copy outside. Thank you so much.
So we'll make it very open forum. You are most welcome to criticize me. And I always, by the way, realize how mistakes I made when I present cases in front of people. So there's always mistakes. So does this move? Okay, so we'll start with the. Okay, right. So we start with the first case. This is a 69-year-old male who presented with a rectal bleeding, underwent colonoscopy at a local hospital, and was found to have a tumor in the rectum at 4 centimeters from the anal verge. As a matter of fact, the tumor spread from 4 to 9 centimeters, so about 5 centimeter rectal tumor. He underwent a biopsy, and that proven to be moderately differentiated adenocarcinoma. His CEA was 5. He underwent an endoscopic ultrasonography at our institution, and that showed that his tumor is T3 and N1. He had an MRI, and the MRI showed T4 and 2. And we commonly see this, the discrepancy between the MRI and the ultrasound. Okay, so let me see where's the tumor. This is the sacrum, and I guess somewhere here is the tumor. And you can see that this is the MRI, and here what I want to show you is that there is no separation between the bladder and the tumor. So that's why the MRI actually called it a T4 rather than T3. Okay? Now, there was few small nodes in the lesions in the liver that the radiologist very comfortably said that those are likely to be hemangiomas and not metastases. Anybody can see anything wrong in this picture? This is the axial view of his MRI. Aywa. So if you look at the iliac bone, there is a bright lesion. You can all see it? Okay. So what's next? So let's see, you have somebody in the clinic. You would go with systemic chemotherapy. Does he have metastasis? Or you would proceed with the chemoradiotherapy, just like localized disease, or you obtain a biopsy from the iliac bone lesion, or will you do a PET scan? And let me tell you that the radiologist told us that he thinks this lesion is malignant. He cannot say that this is benign. So it's a lesion that lights up with contrast, and that's why he could not say that this is something benign. The iliac bone lesion. Okay, so anybody has any comment? You go for PET? Fine, we'll go. You go for a biopsy. Go for PET. So,
because if you have other lesions, then you don't have to biopsy. But if this is the only lesion, then
okay. Reason. Surely?
Bone result, bone biopsy.
We do have good results with bone biopsy, but I think the idea of doing a PET, if the primary was PET positive, and this is PET negative, would you feel comfortable that this is unlikely to be cancer? I think I would, especially if the primary is really has a high uptake and this one is negative. So we went for a PET scan. Okay, so the PET scan showed that it is positive. You can see it. It's light up. So what's next? Biopsy.
Sorry, the other PET scan, there's nothing.
There's no other. The primary was positive, and this one was positive, and nowhere else. Liver was negative. He had no liver.
And for that, I think we postpone biopsy from the initial diagnosis to save our time and to save the resources.
That's true. Except, as I said, if the PET was negative, I would feel more comfortable.
But the other point of doing PET to rule out this metastasis.
That's true. Although you have a CT chest, he had CT chest, abdomen, pelvis. The bones were negative, everything. And I think the CT, and this is, by the way, a common mistake I found with people. I think the CT is much more sensitive than PET, because PET you have to have a lesion that is 8 millimeter to find an uptake. The CT will pick things much lower than 8 millimeter. صح ولا دكتور؟ Sir Mahmoud? You agree?
Well, we talk about, well, it depends which camera you're talking about, but the recent cameras might do much better than that. So we talk about 4 to 5 millimeters probably.
But with the CT now we're picking up 2 millimeters lesion. I mean, in the lung, you pick up 2 millimeter, 3 millimeter lesions.
Yeah,
So-
the advantage is you when it's metabolically active, your certainty is much more than.
Right.
In picking up metastatic disease. With CT, what you're looking for is basically if it's definitely lytic and it's destroyed the bone, or there's a definite sclerotic lesion, then you can say this is metastatic, right?
You're talking about bone in particular.
Sorry?
You're talking about bone only.
Yes, I'm talking about bone.
Only
In
bone.
Yes. Whereas PET may show you a lesion, and on CT you may say minimal change. So PET is much more, I think, sensitive than CT.
So you're
And
like
what-
you can see a normal a positive PET with a normal CT.
Yes. And I'm actually a dual accredited radiologist and nuclear medicine physician.
Well,
So
we
I
do
do
have
nuclear
another
medicine,
nuclear medicine physician, Dr.
No, no, I
Pili, so can we have both your opinion? Because this is very important for us.
Completely agree with it.
So you can have an uptake in the PET with a normal CT scan in the bone.
Yeah. Yeah. Because.
And I've seen many false positive PET.
Yeah, PET will have false positive. That's correct. But PET will see lesion earlier than CT. So in that situation, you can have positive PET, negative CT, and this is really metastasis still.
Okay. So I put for you the actual images where the radiologist actually went in exactly inside the lesion. And we did 2 biopsies. The first one was negative, so we went and we thought maybe he didn't get it the first time. So he went for the second time, and both of them you have fragments. The first one was fragments of bone and marrow with no evidence of metastasis. The second one was fragments of bone and marrow with crushed artifacts. So what's next? So now we've done PET, it's positive. There's no other area. We have done 2 attempts of biopsy, not FNA. Those are core biopsies, and those are negative. You treat as metastatic, you will do an open biopsy, or you treat as localized. That's it.
Include the metastatic, possible metastatic area in the treatment field.
Okay, but it
Because it's pelvis.
isn't it supposed to be treated? I'm not a radiation oncologist.
Yes, but it can be in the field easy. This can be taken easily in the field, and we consider it as solitary lesion or not. But it is very doubtfully. But for the benefit of doubt, for the patient sake, then it can be included in the radiation field.
But if you just allow me, Prof, now if you just look at the lesion, it's so huge. You have a T4 with invasion to the bladder. Giving radiation will be quite extensive and will be a lot of toxicity with that. So, I will make the argument actually, if we're going to keep enlarging the field, it's going to become too toxic for this. I would still agree he needs to be treated as localized, give him the chance. But to be honest, trying to give radiation to encompass everything, even I'm not a radiation oncologist, this guy will be burned badly. I would just truly recommend that something need to be done before we're going to think about the bones and all that stuff.
Yes, please.
Yeah, for me, I will start the patient on chemotherapy first. I will give 2 to 3 cycles and see the response. If the bone is coming down, so most likely I'm dealing with a metastatic disease. If the bone is stable or not changed, I will consider local disease and will treat with the chemoradiation therapy. This is what I am going to think about.
How do you know after this crushing twice it will be? It was positive before, and he has crushed twice in the.
No, positive in once.
For the PET.
No. I'm speaking about we'll give the chemotherapy first and assess the response. If the bone not changing, stabilizing disease, so I will treat with a locally.
You will consider it metastatic. So this is depend on the decision.
Yeah.
If you consider it as metastatic, you will start with neoadjuvant chemotherapy.
Yes.
And then you assess. If you don't consider it as metastatic, this is another possibility, and you start as local neoadjuvant chemoradiation. So both options can be. This is depending on what do you think.
But do you like to give radiation to a tumor which is invading the bladder, Prof?
No, I don't like to start, but I'm not saying, we are discussing the possibilities.
Yes.
For me, I will start chemotherapy.
Only.
I'll start neoadjuvant chemotherapy.
From the radiology point of view, could this be a primary bone tumor?
Yeah, there was a single sequence of MRI available, and that appeared to be a fat suppressed sequence, and that was contrast enhanced, I believe.
Yes.
Right. So there is a lesion there, which is, initially I was just thinking maybe this could be a atypical giant bone island, which can have a bit of PET uptake, can show you bone edema, but I'm not sure they would enhance. So I'm not really sure what that lesion is. You know, and I would be very,
That-
I would very much like to know the histology because you've got the biopsy
Yeah.
of it.
Yeah, both are, as I said, were negative.
Just negative with
Yeah. Just bone fragments and bone marrow, nothing, no malignant cells.
right.
Okay. So basically, just to keep you updated, that sorry?
No intraosseous hemangioma.
No, exactly. That's what the final report I put for you. The radiologist, he kept in mind that one of the differential diagnoses is primary bone tumor. So it's metastasis or primary bone tumor. So how many would go for systemic chemotherapy and how many would go for chemoradiation? How many would go for systemic chemotherapy? Raise of hands. With the two panelists. How many would go for chemoradiation? Is it equal? Maybe systemic chemo is a little bit more. How many would go for an open biopsy? كده حضرتك surgeon?
You say there are two options, but I agree with open biopsy.
Okay. All right. Just to clear up this open biopsy, we spoke with the surgeon and he said, on my dead body. I'm not going to crack this space. He said, we have to crack the pelvis, break his bone to get the biopsy. It's not easy. It's very difficult, so I'm not going to do it. So with this, that's out. And we started him on chemotherapy. We thought we will use chemotherapy as a way of testing if this is, metastasis or not. If he responds, then that's likely to be malignant. If not, so he had 4 cycles of FOLFOX, and we did a repeat MRI. So anybody can tell if there's any difference? 2014, 2015, and I'll tell you what did the radiologist report. It was slightly increase in size.
More enhancement.
So, the primary tumor has responded. This one has increased in size.
Increase?
Yes. So, Khalid, what would you do?
So right now I do have, it still could be a metastatic disease, but I'll give him the benefit of the doubt. And actually, I would say he's had localized rectal cancer with a lesion in the bone, which we are not sure about. So I'll start him now in the new adjuvant concurrent chemo rads and treat him as a locally advanced rectal cancer.
Okay.
For
Fair
me,
enough.
I will go with the biopsy. Again, the repeat
What biopsy? The third one?
The bone marrow. The bone, I'm going to repeat the
Over
bone.
his dead body, the
The
surgeon.
surgeon.
No.
We brought the surgeon to
Not
the
the surgeon.
multidisciplinary meeting.
I will repeat the biopsy.
He said
intervention radiology.
So a third biopsy. Okay, so how about the group here? Yes.
Can I just say, there's a difference in quality of the two pictures. You know, the one on the right and the
Yeah,
one
of course,
on the left.
because I'm not a radiologist, so I don't know which of which.
What I'm actually saying is, to me, without doing an objective measurement, it's exactly the same. Probably not any different.
It's bigger it's big. See, the problem is here you're talking about, those are pictures, but by measurement, it's slightly bigger. Take my word. That's the official report. Yes, sir.
Did we ask the surgeon again at this station
No.
to relook?
No, we didn't, because he said to go after this, he has to break the iliac bone.
Maybe at the start he's still thinking it's maybe secondary, but now if he saw the case again, he may change his decision.
But actually, I'll make the argument, if you give him concurrent chemo rads, you might do actually a resection of the pelvis and a biopsy at the same time if you wish. Why should you expose him to two procedures if you're going to do the procedure first?
No, just to be as a plan for the future. He can take his decision now, so in the future we can decide based on his plan.
As a biopsy, yeah.
But here's the thing, even though he's metastatic, he is a locally, local metastasis. So I would still make the argument now, if it's shrunken down, I can include him in the radiation field, I can do a bone grafting.
No, it's increasing, Khalid. The tumor is increasing.
Now,
the lesions.
I'm just going to come to the point that rectal cancer, still worth actually a surgical intervention for, it's not all the time like this, but for a locally advanced one, having the concurrent chemoras and giving him as a progression-free survival is still worth it. This is rectal cancer, the most horrible thing when you have bleed or local recurrence.
Yes, I agree, Dr. Khalid, with you. Totally, he will need local treatment for the rectum, and this area will be included in the radiation field. But still, we don't know if this area will receive a sufficient dose of radiation without knowing what the pathology.
I'm sorry,
So
we did try twice, and it's negative. So we cannot keep blaming it on the patient. We did try. I mean, here's the thing. There's a lesion I identified. We biopsied twice. I would just say, if you're going to keep hanging our neck on this, patient might lose the chance of having a curative intent.
And if the surgeon, he agreed that during the rectal surgery, he will be able to remove this or to resect this bone thing, it will not be better for him?
Dr. Sabatine.
Primary tumor, did it respond to chemo?
Respond? Yes. He responded.
So, which means that this bone lesion, most likely it's not malignant.
That's what's likely.
No, it's not malignant. Could be secondary pool metastasis. It could be pool metastasis.
Bone
primary.
Primary.
Bone primary.
Okay. Okay, so basically, this is the bone scan, and just to show you that reported as non-specific right iliac lesion. We repeated PET, and PET there was some decreased uptake in the rectum, but no change in the iliac bone lesion. Final decision. We actually decided to do what Dr. Khalid did. So we went in with a concurrent chemoradiation, and he's planned for surgery in the next week or so. Because after chemoradiation, there will be 2-month waiting period or so. And we plan to localize this because it's difficult for the surgeon, for the orthopedic surgeon, to find out where it is. So we plan to do localization before he goes to the surgery, and hopefully we'll take a biopsy during surgery because they will open the pelvis anyway.
Excellent.
Okay? Any question? Maybe, yeah. But if it's gone completely, that's good for him. If it's not gone completely, but we thought that will be one-time surgery because the pelvis will be exposed.
So what about taking the opinion of the orthopedic?
That's the orthopedic surgeon. That's the orthopedic surgeon. We got involved who said, "I'm not gonna touch him."
Even now.
Now, when we open him for the rectal resection,
he could change.
He will go.
This is one.
He will go.
Yes.
So the same procedure, same anesthesia.
Okay.
This is not the face or side. Giant cell tumor, I thought it has a specific features, right? Apparently, this was not raised at all as one of the possibility, and I don't know. But with all the MRI and CT scan, because it's there also on the CT, the giant cell tumor was not raised. Okay, so lessons from this. Maybe you can give us.
If you have a patient which is problematic, send them to King Faisal or King Khalid.
To die there. To die there.
No, well, I'm sorry. I'm just gonna say, we need to know the final pathology. But I mean, we know actually colorectal cancers very common to have metastasis. Now, liver metastasis is the classic one we always keep talking about. But other patient can be still salvaged even if you have a localized metastasis. And for a guy like this, I would say it's very tough to give up on him with no confirmed histological diagnosis. I mean, we keep talking about the non-specific lung nodules, deny patient from therapy, and all that stuff. That will be a very tough decision. So we need to be very careful in how we're going to make those decisions.
There's 2 questions over there, and then yourself.
Yeah, I think we have offered this patient all the local regional treatment can be offered. He received surgery, he received the radiation. So it doesn't matter a lot that it is metastatic to iliac bone or not, unless we consider for further systemic treatment. Other issue, the liver lesions, the 2 liver lesions are small, I think subcentimetric. I don't know. We can rely on the PET scan or not on such liver lesion.
No, MRI. An MRI confirmed that those are hemangiomas.
Hemangiomas, okay. Thanks a lot.
Please.
So if this patient have no iliac bone metastasis, you will go for neoadjuvant still or concurrent chemotherapy directly. Because even if T4 without fistula, we can go for chemotherapy. So I need to know your opinion regarding systemic chemotherapy in T4 lesion without solitary bone secondary, so that without suspicious lesions.
I mean, the indication is very clear for the chemoradiation, neoadjuvant chemoradiation, T3, T4 are positive lymph nodes. So there is I'm not radiation oncologist, but Prof. Qandil is here. I know there is a risk of more complication with T4. However, it's not contraindicated. And the best treatment actually to give neoadjuvant chemoradiation therapy.
I'm just going to say, like, it's a practice point. If the patient is symptomatic from a fistula, like he have a clear things, typically we avoid radiation. If there's a very clear evidence on the CT scan, like the contrast, like sweeping from one side to another side, typically we do not proceed with the concurrent chemoradiation. Apart from that, we can start with the chemoradiation. Now, typically the radiation actually will say, this is too big for me, too much toxicity, please shrink it down. So typically it's not a call by a medical oncologist, it's a call by the radiation oncologist, say, shrink it down a little bit for me so I can give him a better, higher dose, I can achieve better remission.
So, Prof. Qandil, is fistula contraindicated for chemoradiation therapy?
Fistula, it's not a contraindication. You can do diversion. But
yes,
before
that's
starting, you should do urinary diversion.
Stoma diversion. Yeah.
Yes.
Before starting.
And that's why symptomatic fistulas or a clear thing in the contrast, typically we do diversion straight away. Actually, the surgeon will take care of that.
So this is a quickie one. So this is a 65-year-old female presented with a vague abdominal pain for 10-month duration. That was followed at a later stage by coming with intestinal obstruction. So she was admitted to a local hospital with intestinal obstruction, underwent a CT scan that showed mass in the left colon. That was done at the local hospital. Unfortunately, I don't have those films. A colonoscopy also was performed and showed mass in the descending colon, and a biopsy showed mucinous adenocarcinoma. So April 2013, she underwent left hemicolectomy. It was kind of like an emergency procedure. She did, apparently, according to the operative notes from the referring institution, develop bleeding intraoperatively. And post-operatively, about 1 week later, she developed pelvic collection. She was taken back to the operating room, and there was an evacuation of a hematoma. So that's the second OR that she had. 2 weeks later, while she's still in the hospital, she developed fever and was found to have a subphrenic collection, was taken back for the third time to the OR and had drainage of that collection. Post-operatively, she developed wound infection and chronic drainage from one of the drain sites would not close, and later on they found that this is a fistula. The final pathology was T3N0, high risk stage 2. Anybody know why it's high risk stage 2? Because what? And if she did not have obstruction? No, she had no perforation. Less than 12 lymph nodes. So less than 12 lymph nodes. Okay, so the patient was referred to us for adjuvant chemotherapy. And we saw her, the medical oncology. At that time, she had a performance of 3. Her abdomen had a large dressing which was soaked with purulent discharge. So at this stage, if you're faced with such a patient, what would you do? You would give, she was given a 1 month return appointment for recovery. I spoke with our surgeons, and our surgeon did not want to touch her because she was operated outside. And they said maybe the best person to actually deal with it is the surgeon who has operated on her. So sent back to the local hospital over there. The surgeon once again did a CT scan. Unfortunately, I don't have those pictures, and it shows multiple abdominal collections. She later on developed 3 new sinuses, so now she has multiple openings in her abdomen with the sinuses, and came back to me after 1 month with all those draining sinuses. I sent her to one of our greatest surgeons in the hospital who have looked at the CT with all those collections and decided that this is abdominal carcinomatosis and said you should start chemotherapy right away. I wanted to tell you that she did have an outside PET scan done at Al Habib Medical Center that had variable uptake. I unfortunately could not open the films. We do have the CD, but the films could not open, and I could not give you those. She had multiple positive uptake in the PET scan in the abdomen. So what should we do? Should we start palliative chemotherapy in this case? Refer her back to the surgeon, say, take care of her. She has multiple surgical problems. We're not going to take care of her. All refer to King Fahd Medical City Surgery Department.
I think that's the best options.
Or start adjuvant chemotherapy, which in this case, capecitabine will do, right? For stage 2 colon cancer. What would you do?
Actually, with this.
I mean, if you're on a stage. So let me just ask the panelist, Khalid, what would you do if you're faced with such case?
Now, I mean, if we do believe she's metastatic, I'm sorry, her CEA was elevated.
I do have the CEA value, but I don't want to show you because otherwise you'll see. I think it was borderline.
I see. Now, it's
3-ish.
right. Now, it's a case, complicated post-operative course with a new development of lesion, which we do believe they are new and high uptake on the PET scan, right?
There's an uptake on the PET scan. The uptake is not very strong. We're talking about SUV between 3 to 4.
Right. Which is new, right?
I mean, we don't have a previous PET scan.
Right, but
and she does have collections, by the way, in the abdomen, multiple
scan
collections.
was done there, right?
Yes.
Now, if the biopsy are so superficial, we can do biopsy from them. But if not, to be honest, I'll start her on chemotherapy if she can tolerate that. Start single agent, Xeloda, capecitabine. Now we need the KRAS mutation, so we can decide about if we're going to add an anti-GFR. She just post-op, so Avastin might be if the questions about that.
She has multiple sinuses, discharging sinuses in the abdomen.
So in this case, at the most, if I can believe that she can tolerate chemotherapy, I'll say chemotherapy treating her as a metastatic disease.
Performance 3, by the way, huh?
No, then actually I'll back off, maybe best supportive care until...
Best supportive care.
So for me, Shawqi, I do believe we should investigate more about the sinuses.
Okay.
It's unlikely to be, tumor, very quickly tumor relapse, sorry.
بس لي الكمبيوتر لو سمحت.
أهم شيء جوالي. I don't believe we should. Sorry يا شوقي. تحمست هذا حماس. لا جيبوها بالصورة. I do believe we should investigate more about the sinuses.
Okay, so this is where a surgeon is telling you, and I'm not going to operate on her. This lady had multiple sinuses. This is most probably carcinomatosis. Why should we have those sinuses?
Right.
That's what the surgeon was saying.
I mean, 4 weeks after surgery, you will.
No, it's a little bit more than 4 weeks.
6 weeks, 8 weeks, whatever.
8 weeks.
8 weeks.
No, after the last surgery, remember she
Yes.
had 3 surgeries over there. So it's actually even more than. We're talking about 3 months after surgery.
I will be very hesitant to start chemotherapy till I approve the diagnosis. She could have collection. It could be an abs collection, or I don't know what we are dealing with. So I will be very hesitant to start chemotherapy, especially she's stage 2.
No.
Initial.
Right. We don't have any surgeon over here, correct? No. Doctor.
I think also, I don't know what's the cultures. Did she respond to antibiotics before or not?
She was given, I mean, when I first saw her, and I gave her a month appointment, initially when I saw her was 1 sinus. When she came back after a month, she had 3 more sinuses. During that time, she was on IV antibiotics.
She had antibiotics.
During this time, for the whole month, she was inpatient at the local hospital having IV antibiotics.
I have personal experience with those patients. Whenever the surgeon comes with, especially with mucinous, what has striking me with this mucinous histology, and tell you that there is a collection after surgery and hematoma and this, it will be recurrence in most of the cases. In most of the cases, especially with mucinous histology. But for me, I'll start antibiotic again for 2 weeks or something, if this is improving or not improving. If not improving, I'll try to get biopsy. If not possible, then I'll start her with chemotherapy under cover antibiotics.
Okay, so you'll admit her under medical oncology and treat her with IV antibiotics.
I'm also arranged for that.
Okay, well, as I said, our surgeon did not want to work on her, and her surgeon even did not open her up for the 4th time. He opened already 3 times, so I don't think he was not much interested. Anybody would do anything differently or have any idea, please, Doctor? Yes, Mike.
Actually, for this unlucky lady, complicated post-operatively for left-sided colon cancer, I would like to go for adjuvant chemotherapy, and I will be even reluctant to do so. I may skip it by any. I may go for microsatellite instability, and this will help this dilemma over at this stage 2 high risk. It will not benefit from adjuvant chemotherapy, so this is not my case. Actually, her time passed for adjuvant chemotherapy. We are talking about more than 3 months post-operatively, and the benefit of chemotherapy in this case would not get the much benefit of adjuvant chemotherapy. Actually, the patient is still in performance 3, having abdominal sepsis. I think if we give her anything as adjuvant, we may flare her condition that we don't know. Actually, I cannot rely this patient has a local recurrence or abdominal carcinomatosis. I don't have a proof of that. PET-CT may not be conclusive as there is multiple infections inside, and even if it came high SUV, we have documented multiple collection and infection inside the abdomen, so I cannot rely on PET-CT for defining this. This patient is unlucky. Her primary surgeon cannot open her for the 4th time, and any other surgeon will not open it after him. This is a cardinal rule of surgery. I don't open after.
Right, but I will make now a counter argument to you.
Yeah.
If this lady had a carcinomatosis complicated by the sinuses, giving her an anti-EGFR, which we hope that she is like a wild type with a little bit of chemotherapy, might stop the tumor from acting up. So actually, this might give her a better chance of healing of the sinuses. So the whole idea of the chemotherapy becoming palliative, improving her quality of life, rather than just like prolonging her like overall life. So, and to be honest, like I'm not confident that she have a metastasis. I agree with you, but I cannot ignore the fact that she is having. I mean, she might be. This is all complication from the sinuses. Now, the problem, I'm not sure. Like this is like a local. I mean, another recurrence or just like a part of the infection. I need to confirm that. Like that's why I need to sit down very closely with my top friend in interventional radiology, ask him if we can biopsy something out from those abdominal masses. This is the only way I'll be confident, but. To be honest, for a lady which is such in a miserable condition, I will try to give her an anti-EGFR if I can.
But actually, sir, just prove that you have a local recurrence or metastasis, and you can, as a medical oncologist, start treatment. And any treatment will be started now without an evidence of local recurrence or metastasis will be under the adjuvant chemotherapy.
Yes.
Which is not
And
reliable.
that's why,
which is not reliable for this case.
I was hoping actually her CAA will
EGFR.
be like 100, so I'll be much more comfortable that she is a metastatic disease. If her CAA was 100, I'll be.
No, it was actually CAA is about 3, so this is much. It was how much was it before surgery?
I don't have that data. It wasn't done. It wasn't done. They don't do it before
So
surgery.
let me ask Khalid, are you going to treat the patient based on CA level if it's more than 100?
No. So actually, this is always the big debate. Shall we biopsy every recurrence? And actually, let's be clear. Now, if a recurrence happened within the first 2 years, whether the other evidence of new evidence on the CT scan and with the evidence CA, I will not rebiopsy.
Sure.
So this is the lady does fit this.
Within 6 weeks, do you think
No,
carcinomatosis?
doctor, it's not 6 weeks. I mean, the last surgery was done, and then she was referred to us. She wasn't referred directly from the last surgery.
Because she had a both
and I think what we're saying now with this sinus is definitely 3 months from the time of surgery.
Okay.
So I'm just not saying. I mean, I'm not going to rebiopsy everything.
So she was actually operated in April. In June, she was seen for the first time.
And you did the scan at that time, Shawqi?
Right, and then she came back a month later, and she has multiple. So we're talking about three months.
Right.
And I have there's one earlier question.
Yeah,
or
just want
comment.
to clarify how much credence you should give to the PET CT here, because this is a mucinous tumor, so FDG uptake would be low because of low cellularity. So don't go by SUV maxes here. This is a tumor which would not be very FDG.
That's even more argument now.
So what are you trying to say? We should treat her based on.
No, what I'm saying is, first of all, you've got a conundrum that you've got in sinuses and collections.
Multiple.
So as you know, FDG uptake can happen in infection as well as in tumor. But the type of tumor you're dealing with, even that is not meant to be very FDG-avic. So, with SU max of 3 or 4, PET CT would not help unless you correlate it with diagnostic CT and contrast enhanced CT.
And the diagnostic CT, there was no masses, there was collections.
Yes. So I don't think we have, imaging is going to help you.
Right. There's no, they were not solid masses, they were collections.
And you should exclude the chylomicrosis.
Fungal infections.
It's rare, but it presents with signs. I have one patient like
TB, tuberculosis also.
So let's see what happened. The patient then came back to me in December. She went to Germany. He got fed up, her son, so he took her to Germany. Over there, she had laparotomy, drainage of all the abscesses, resection of small bowel fistulas, closure of fistula. No cancer was found. Okay? Creatinine was 159, I think, then it came down. This is the CT PET. At that time, really not much minor uptake, as you could see here, but no residual collections that were found actually after. So now, no evidence of metastasis, no hydronephrosis. What would you do?
Shawqi, so did they give her chemotherapy?
No. Just no. She went to a surgeon over there, a good surgeon.
So excellent.
No, just like regular follow-up.
Okay, so now regular follow-up. Yes, sir.
This was my point, my question actually for this slide. Actually, when the patient comes from another center to first center like King Faisal or King Fahd, and they are sending him to the primary surgeon again, this should not happen, because we send her to lower experience again, we decrease the chance of patient cure. So I think once the patient came to highly specialized center, he should dealt with our surgeon, not with local surgeon again.
I agree with you, but I wish the surgeons are here. They are not here to defend themselves.
Yes, it should be regulation from the management of the hospital.
I agree with you 100%. And I actually fought so much. I sent her, the colorectal surgeon refused adamantly to touch her. They refused to see her. They refused to see her at the clinic.
So I think the best...
the oncology surgeon is the one who saw her and returned her next day. She said, this is carcinomatosis. She needs chemotherapy.
So I think the best chance was to send King Fahd Medical City.
But then we sitting here discussing this without the surgeons, by the way. And I think next time we need to have surgeons.
She went at this surgery in Germany. She went at this surgery. They didn't return back to...
Did you?
But German.
I'm sorry, there's financial interest into that. So if she went to see a surgeon, the surgeon will be very interested.
Khalid, you disagree.
No, it was a good decision. Yeah. It was a good decision. I'm not saying that, but I'm just defending our surgeons.
Our surgeons should have operated on her. What he's saying is absolutely true. This guy, 3 times, and he was unable to do a good job. Why should we say she should go back to the primary surgeon once again?
That's King Faisal.
Okay. That's. Once again, it's unfair because they're not here. They need to be here. Maybe next time, I think what we learn is we should, when we have surgical cases, we should invite them so that they can actually give us their at least viewpoint. Okay. So we followed her up. Of course, the window for adjuvant therapy was over, usually about 6 months. If after 6 months passed, we don't give chemotherapy. And there are data on this. And about in March of 2015, a CT scan showed this lesion next to the kidney.
Send her to Germany.
What would you do?
Now, here's the issue. So, we know actually colon cancer, progression-free survival for 3 years is equivalent to 5-year overall survival. She's still recurring within the 2 years, so she still have a recurrence. I would like to know her CA, do the PET scan, and take it from there. Now,
CA was 4.
So slightly
The
right.
normal is 3.4. She's 4.
And sorry, PET scan was done or no?
Do you want PET scan, Dr. Tooley?
I would like. Is this a new thing?
That's a new thing.
Is this a new, this lesion around it?
Absolutely new.
It's a new.
Completely new.
PET scan.
Anybody wants a PET scan? Dr. Tooley, you want a PET scan?
Yes.
Doctor, you want a
It's
PET
a solid
scan?
lesion. It doesn't look like a particularly,
Yes, that's a new solid lesion, yes.
PET scan is show.
there is avidity. So
Then surgery.
But, many of you don't have a pet in their hospital, right? So what would you do?
Send it to you, actually.
Biopsy. So this is the PET scan. This is the lesion.
Okay.
It's negative.
Good.
So what would you do?
So at least now I'll be very happy that there's a chance this is not metastatic. Now I don't know what is the nature for that. The CA is not strikingly high. So now
This is the CA.
Yeah, it's not
I
strikingly
put for you.
So I would actually suggest to do a biopsy from that. It was significantly elevated. If it was an SUV of 10.
Shawqi, this is the only lesion there?
This is the only lesion.
And it's surgically resected?
Resected?
Resectable.
Resectable?
Yeah.
Yes, it was surgery resectable.
Okay. So, refer him for laparoscopic surgical resection.
So you would go for resection without biopsy.
Without biopsy.
You would go for a resection
I would go for a resection or a biopsy.
or a biopsy. So why did we do a PET scan?
No, I'll tell you why, Dr. Shawqi. Now, if there's other metastasis somewhere else,
Yes.
will make a difference. That will be number one. Number two,
So let's talk with the stakeholders. He said, CT in the abdomen. CT is more sensitive or PET scan?
Well, the PET scan there was used for the PET scan because you assess the whole body. So instead of only this
No,
one-
but we do CTs. Why we do CTs if we don't see any abnormality in the CT? Where the abnormality is gonna pop up?
No, when you have abnormality seen on the CT, then PET scan is indicated to assess the metabolic state of
That's of a lesion that you know.
Colon cancer. 3 years
Plus,
later,
we get a
laparoscopic
chance to see the whole body.
That's true.
So that
So you still in retrospect, even though now it's negative, and people won't still go to surgery or biopsy, you still think that the decision to do a PET scan was correct. Won't overload the PET scan schedule, huh? Okay, I agree.
Although, Dr. Bazabashi, just when you showed us the contrast enhanced CT, if you go back to that slide, and that's why I asked you whether this was a new lesion, the enhancement characteristics are very similar to spleen. And I was just thinking whether this could be a splenectomy.
Completely new.
But
Completely
it's
new.
completely new. And there was, unless there was a splenic rupture.
It's very much separated a little bit from the spleen, correct? Yani splenule will be a little bit closer.
but just subphrenic abscess.
Okay, who would go for surgery right away? Who would go for a biopsy right away? Let's go for surgery.
No,
Who would go for surgery right away?
Full staging.
عملنا full staging to PET to CTs. What else you want?
Go ahead for surgery.
So who would go for surgery right away?
Why?
I'll tell you in a minute. Who would go for surgery? 1 2 3 4 5 6 7 8 9 10 Who would go for a biopsy?
She should be evaluated.
Biopsy, only one.
She should be evaluated for HIPEC.
Who's talking? Sorry.
We should.
That's a possibility. So maybe let me see what we have put as an option. So we can all go for a biopsy or laparotomy and resection or start palliative chemotherapy or just follow up. Those are 4 options that we have until you have opted for number 3, correct? Okay, and we have the majority went for the second option, laparotomy and resection.
And I'm going to
Okay.
just say Habit might not be a good option. She had a multiple surgery before, so there's tons of adhesion, and this looks like retroperitoneal on top of the kidney.
And it was a negative.
To
When
be,
they did the- when they did-
considered, but
Okay.
somebody expert in the field.
So we did the biopsy, and we went for the first option. And the biopsy was desmoid type fibromatosis.
Great.
Okay.
How this is like a colon cancer.
So options.
Surgical resections.
Surgical resection.
Yeah, desmoid type fibromatosis.
Any other possibility? By the way, just to keep you, we wanted to be 100% sure that this is actually desmoid mass. So we did a second biopsy, and the second came the same. So now we have two biopsies, which is desmoid type fibromatosis. So options of resection, tamoxifen, doxorubicin chemotherapy, non-steroidal Solindac, or observation. Who would go for which?
I'll go for resections.
Resection. Okay. We don't have surgeons, huh?
Send it to Germany, يا شباب.
Okay.
Send it to Germany. I am agreed for
Anybody
that.
have read about the desmoid tumors that comes with colon cancer? That, by the way,
VAB syndrome.
Ghana syndrome, and with FAP.
VAB
Commonly.
disease.
Okay, and they tend to recur frequently post surgery. So the surgeons refuse to operate.
I think you have a problem, Shafi. Close the department. Shafi.
So the surgeons refused, and I gave her son the option of either tamoxifen or observation, and he opted for observation.
Why non-steroidal, يا شوقي?
Sorry?
Why non-steroidal?
That's one of the therapy for.
Yeah, why? Why not? Why you start with tamoxifen? Usually we start with NCID, non-steroidal.
I don't know why.
Okay.
Repeat CT in September, no change. Okay? So that's September. And the next CT, inshallah, in December, I'll let you know later on. Any question?
On time, Shafi.
طيب, thank you very much for your contribution. Thank you for listening.